For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up. Season 3, Episode 30 of Surfing the NASH Tsunami, our preview of EASL 2022, starts now.
This week on Surfing the NASH Tsunami.
Steve and I had a conversation 4 or 6 weeks ago, not on this podcast, about the level of drug discovery being presented at this meeting being relatively low to what people had become accustomed to in recent years. One of the reasons for that, I think, being in the aftermath of Intercept and the pandemic, all the drug trials slowed down.
For sure, clinical trials slowed down. We probably are seeing an impact of that at this year's meeting. Just look at liver biopsy. You had endoscopy suites shut down, IR suites shut down, and that was probably the largest percentage of things that were shut down.
On the other hand, Stephen, I'm really excited to see some of the clinical trial data going to be presented. We're not allowed to discuss them today because they're embargoed.
There's a little bit of a theme through what I can see with the posters and the presentations. It's about real-world data. It's about, well, how do these scars conform with each other's?
One of the things we've been talking about is how the effect of steatosis versus fibrosis and how bad does the liver have to be for the quality of life score to be affected, and this says not all that much. Their definition of advanced fibrosis is less than F3 and a VCTE liver stiffness of less than 8 kPa, fairly low. Basically, those patients without NASH do worse than the overall population.
I think this is a very important study because it highlights this frequently neglected aspect of how a patient feels and functions.
Where I think this is most widely applicable is in really helping to build the premise that we need to be screening for these patients, because how a patient feels is often overlooked relative to progression to end organ damage.
I thought this study was incredibly powerful because right now we've got doctors all over the world saying to patients, you've got fatty liver, but don't worry about it. And you got this study saying that if you've got steatosis all the way up to cirrhosis, certainly up to fibrosis of F3, you're going to have a negative impact on quality of life.
This is incredibly important because we are in the middle of a renaissance. And this renaissance is we want to move away from liver biopsy. We want to begin to find simple, non-invasive strategies to risk stratify our patients, to prognosticate our patients. We have begun to do that.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researchers and key opinion leaders Professor Jörn Schottenberg and Dr. Stephen Harrison, liver wellness advocate Louise Campbell, and pricing and forecasting guru Roger Green, as they preview next week's International Liver Congress 2022, this week on Surfing the NASH Tsunami.
Today's episode of Surfing the NASH Tsunami is sponsored by Madrigal Pharmaceuticals, a clinical-stage biopharmaceutical company pursuing novel therapeutics for NASH. Madrigal's lead candidate, resmetirom, is a once-daily, oral, thyroid hormone receptor beta-selective agonist that is designed to target key underlying causes of NASH in the liver. Resmetirom is currently being evaluated in 2 phase 3 clinical studies, MAESTRO-NASH and MAESTRO-NAFLD-1, designed to demonstrate multiple benefits in patients with NASH. For more information, visit www.madrigalpharma.com and be certain to listen to the summary of Madrigal's presentation at this spring's Chronic Liver Disease Foundation conference after today's main discussion.
Welcome to everyone who was with us last week for the Global Liver episodes. And before that, I guess we've had a pretty eventful month with that and Quentin's week on NITs and then Stephen's week before that on drug development. This week, we're going to preview, the 4 of us are here, we're going to preview some of what we consider the interesting papers of 2022. Next week, we will have a different kind of preview episode where we'll be interviewing some of the folks who are part of the meeting. And then we will have live episodes or same day episodes posting Friday night and Saturday night, the 24th and 25th of June, going up the next day. I will be hosting on Friday. Louise actually will host on Saturday because I have to fly back to the States. I'm going to sadly miss the late breakers and a couple other things, but get to be there for most of the meeting. And then we go on after that. So, except for the fact that it's June and it's lovely here in the States, Stephen, I hope it's not still 40 degrees in San Antonio. How are you doing today?
I'm doing great, but it is still 40 degrees Celsius, I guess. I don't know. That sounds like a lot. In Fahrenheit, that's about 100.
That would be 108, Stephen. Yeah. 40 would be 108.
Well, we were 108 yesterday. Today, I think we have a cool wave coming through. We're down to 104.
So that would be 37. All right. But still pretty good. Pretty good.
And the 10-day forecast does not have us breaking under 100 degrees Fahrenheit. But it's good. That's why we have pools and lakes and rivers and, places that we can go get out of the heat.
So, Jörn, I'm guessing it's not quite that hot right now in Germany.
No, we got about a 70 Fahrenheit here, 21 Celsius. It's a pleasant afternoon. I got my run in already, so now I'm all energized for this session.
Superb. Louise, how are you today?
I'm fine, thank you very much. It's nice and sunny, and we are going to hit 30 by the end of the week here, so we're getting warmer. And it's Royal Ascot week.
Yep, on the weekend. So when we get there next week, what's it supposed to be
68 to 70 is the hot Fahrenheit.
I was going to say, it's a little bit colder for looking at the weekend, and wet. But I don't know by Wednesday, but you do need to be advised there is a railway strike 3 days of next week, allegedly so far, which could cause a bit of a problem with the conference. But let's hope it doesn't go ahead and we all get there to and from.
If not, I booked myself 7 minutes walking distance from the XL, so I'm not that worried about that once I get there. I think I can stay off transportation. But...
I'm 45 minutes away and requiring some sort of motorized transportation. So, yeah.
You're brave.
Train goes down.
So, Steve, did I hear you say that if trains go down, you're 2 hours away?
Probably.
We'll be putting up bunks for you at the conference center.
Mm-hmm. Yeah, we'll get a roll away in one of our rooms. It'll be great. Yeah, it's about 30 degrees here today, or 85, depending upon where you live in the world or how you count temperature, and perfectly delightful. So that's a good thing. All right, with that, why don't we just get started? Okay, one good thing that's happened for everybody in the last week. Brave one, go first.
I'll jump in. International NASH Day, I thought, was a resounding success last week, and I really enjoyed all of the sessions. The one that we missed for covering for the sum up was the NAFLD in black children, which was fascinating and extremely interesting. And a family shared their story, which hats off to them, and very, very brave. They were absolutely superb doing it. So a big shout out to International NASH Day and the Global Liver Institute and everybody who got on board. It was really, really good last week.
I spent a day in Vienna last week visiting UEG, that's the United European Gastroenterologists, and we were planning for this year's abstract sessions. So the meeting is in October, and part of that scientific steering committee that combines the abstracts for UEG, being responsible for the liver section. While UEG is more focused on gastro, I guess, comparable to DDW, it's very exciting to see how much strong abstracts are coming into that field too, and it's always fun to discuss the program with the colleagues and set it up, to inform our GI colleagues about liver disease.
Very nice, Stephen.
This week is the week before EASL, and anybody that is around me the week before AASLD or the week before EASL understands that it's a crazy busy week. So it's just all about getting lectures ready, getting itineraries and schedules firmed up, last minute add-ons, that sort of thing. So haven't really had time to focus on much of anything else. It's all about prep for the meeting. So
Stephen, I don't recall, you've told this podcast about the piece of art behind you. I don't recall whether you've ever exactly described it. So can you explain to our audience, since you're usually so good at pointing out what's in other people's backgrounds, what that piece of art is?
Oh, yeah. So this is a bit of abstract art where we commissioned an artist to just come up and free associate. He looked at where the house is, and he talked to me about what I do for a living. And so this is what he came up with. In a nutshell, to make it really simple, the letter is an L, and that thing is a replica of the liver with a right lobe and a left lobe. So it's the lake and the liver all put together, and it matches very nicely with my boat, which is named Cirrhosis of the River.
Ooh.
That's fantastic.
Okay, we have a winner for bad puns for the month of June, folks, and it's only the 13th. That's superb. So, Stephen, before you did that, I was going to say that
I didn't know if you would get that. It took you a while. You had to let that sink in.
No. I had to let it finish hurting first. I got it immediately. It's just the pain was at any rate. So for those who are listening, The picture that we post for promo for this episode on LinkedIn will have Stephen's art in it, and I will see if I can grab a video snippet that we can put up on YouTube that has Stephen explaining his art, because I think it's worth it. My week, I think the best thing is that I feel like I'm back to normal. I was, as you all know, down for a couple of weeks with COVID in varying degrees. And then last week I had 3 weeks worth of work to catch up on in one. The diabetes episode is now out. We got through all the recording around NASH Day, and then on Thursday I crashed all day. But this week, back to myself. I biked 15K in hills on Saturday. 15K is not a long bike ride, but in hills it feels like it. So in 28 degree weather. So that was good. And this is going to be a normal week. And next week we'll all be in London. So that'll be exciting. And speaking of London, we're there for ILC. It'll be the first time ILC has been in person since 2019, I guess, right? In fact, it will be the first of the major conferences that's been in person since 2019. So this should be a real thing.
The only conference that we've had since 2019 in person consistently every year was NASH-TAG.
That's true. I guess CLDF could claim the same thing for Liver Connect, but they only started in 2020, so they don't have continuity going for them on that. I think that's right. The only one that's been both years and existed before that would be NASH-TAG. Hats off to you guys for doing that. Format's pretty simple. We've each picked 2 or 3 posters or presentations that for varying reasons we think will be really interesting. And we're going to go through as many of them as we can get through in the next hour with somebody, whoever came up with a particular presentation, picking the one they came up with, and then talking about why you're interested, and the rest of us asking questions and making comments, and we'll get through as much as we can, and that'll be it for this week. So let me do Brave One go first.
I can start. So the first presentation I'd like to discuss today is oral presentation number 97, given by Jenny Lee. It's data that comes out of the LITMUS Consortium, actually. So the title of the oral presentation is Machine Learning Algorithms Identifying Novel Biomarker Combinations for NAFLD. For a number of reasons, I think this is a very appealing abstract. A, it's data that was generated at a number of expert sites prospectively. It's actually detailing the Metacohort of the LITMUS Consortium European NAFLD registry. As such, you get a diversity of centers contributing. So much more diverse than, let's say, a clinical trial that focuses on certain inclusion-exclusion criteria. All patients underwent liver biopsy, so you're able to characterize them based on the disease activity and stage. For this poster, 720 adult patients with NAFLD were actually analyzed. 540 going to the training set, 180 to the validation set. 53% had NASH, 26% advanced fibrosis, and 7% cirrhosis. The authors then went on, and for each component of NASH that we're looking at, steatosis, inflammation, and ballooning, as well as fibrosis, they did a gradient boosting method, GBM analysis, to develop a number of classifiers and rank them and see what correlates the strongest with those histological criteria. So in the end, you come up with an expert center liver biopsy cohort, which is fairly large, 720 patients, read by expert hepatologists in the field, but outside of the clinical trials. And the top findings is that they detail the characteristics for these histological features, as I said. And if you then look into table 1, and they already have that in their abstract, steatosis is most strongly predicted by body mass index. Inflammation, interestingly, most strongly by hemoglobin. And ballooning, they have the BMI again. And fibrosis here, and that's no surprise, I think VCTE comes in on place 1. So it's a little different look at how we normally explore histology. They take the individual components and look at certain clinical or lab values that correlate with them. It's a nice way to add to the granularity to see what is actually happening in these scores, where we ask about NASH and advanced fibrosis, but the different components, to what extent are they actually correlating with some of the features that are being treated in practice.
Jörn, did Jenny mention anything about diabetes relative to fibrosis or ballooning, and not only just the presence or absence of diabetes, but the longevity of it and then the control of the diabetic? So I know there's been a little bit of debate about both how long you've had diabetes and whether that links to severity of disease, as well as the severity of the diabetes linking to the severity of disease. In other words, an HbA1c of 10 might give you worse disease than an HbA1c of 6. And while that's still being sorted out, this would be a great data set to analyze that. And having not apprise myself of the abstract. I don't know if that was looked at, but I didn't hear you comment on diabetes.
Yeah, good point, Stephen. And so diabetes is in the equation actually as the fifth component to predict or be associated with fibrosis. So A1C here, to be more concrete, is part of what the GBM identified to be associated with fibrosis. Now, interestingly, it's not in the top 5 for steatosis, inflammation or ballooning, where I would have also expected it for the presence of NASH, but it comes up in fibrosis. The length of diabetes is a little difficult, I think. We've tried to look in that and also for our data set. And while the patients can normally tell you when they went on drugs, that might under-capture the reality of the diabetes duration or also the extent of diabetes manifestations. And as such, I think it's too difficult to capture it outside of truly predictive protocols in these type of analyses.
Yeah. No, that's interesting.
Okay, so the only other thing I would like to say is that within LITMUS, we actually did CK-18, and we have that on a fairly large data set. And within that analysis, it actually comes up for steatosis and fibrosis, which, CK-18, there's been a lot of discussion about it. I think there's been some variabilities. If you look at the older tests, more recently more robust, there's the MAC3 score, which uses it. And so it comes up every once in a while again. If you look at it as a single marker, I think it's a little volatile. But here in this analysis within LITMUS, Jenny sees it again. So it'll be interesting to learn how they put that in there.
That should be fascinating. In fact, a lot of what I found most interesting in this program were not necessarily the original research, although some of that was pretty good, but the kinds of thing going back and looking at some of the very large data sets and being able to glean detail that you really couldn't if you didn't have that kind of data set to look at. So I think that and several other papers like that should be fascinating. And thanks for starting there. Who wants to go next?
I can jump in next with one. My pick, or one of my early picks, is going to be out on Friday, and it's presented by Roberta Fulano and the team at Imperial. I suppose this is a special one because it was one of the protocols that I got to have a look at before we started doing this one, before I left Imperial. And it's a clinical and economic evaluation of community-based preventative screening strategies for non-alcoholic fatty liver disease in people with type 2 diabetes mellitus. This was interesting because they were serial fibroscanning patients in a diabetic centre. And we don't know the exact prevalence, so that's what they were set out to locate. So they aimed really to determine the prevalence and develop a risk stratification and cost analysis for the screening policy in type 2 diabetics in primary care. And we discuss a lot about primary care, and I know Marsden's done some work on the cost effectivity. So this again was to sort of, was it going to support what we discuss? So they consecutively recruited patients who then went under blood tests, ultrasound and liver stiffness by FibroScan, and they defined anything over 8.1 as significant liver stiffness and 12.1 with a diagnosis of cirrhosis. So they then included 3 health states in a Markov model. So no NAFLD with liver stiffness of less than 8 kilopascals and significant liver stiffness and cirrhosis. And they looked at the probability of the progressing. So I think they also did a cost-effective analysis with a threshold set of £20,000, English pounds, as gained by NICE. So they recruited 300 patients, 287 were included, 13 withdrew, 73% had NAFLD and 28% other causes of liver disease. But it was the levels of fibrosis and advanced fibrosis that were important in this. So advanced fibrosis due to NAFLD, 17% of that population, and 11% had advanced fibrosis. So 70% had significant, 11% had advanced, but the prevalence of cirrhosis in that population was 3%. So these are significant numbers from my perspective with patients with type 2 diabetes.
Remind me again how cirrhosis was defined.
Cirrhosis was defined here as a FibroScan of over 12.1 kilopascals. Was clinical, histological or radiological Markov model included 3 health states. So no NAFLD with liver stiffness less, and significant liver disease above 8.1 kilopascals and compensated cirrhosis. So there was other histological markers.
So I would challenge that. If all they did to define cirrhosis was a KPA greater than 12 and they only found 3%.
No, the diagnosis of cirrhosis was clinical, histological or radiological. So they did biopsy a lot of these patients.
But it was or. There was or there. It wasn't and. If it were or, that means they could be the diagnosis at a KPA of greater than 12 all by itself. Am I misunderstanding?
No, that appears to be the case.
So if that's the case, at least in my hands, that if I applied those same criteria, 50% of my clinic would be cirrhotic, maybe more. People have to wrap their brain around the fact that FibroScan positive predictive value is incredibly low, particularly if you're studying a general population or a diabetic population. You're not studying a transplant population where we know the underlying degree of fibrosis is significant. Now, this is why we came up with FAST. This is why there's Agile 3+, there's Agile 4. This is why the ACE guidelines, the AGA guidelines, the EASL guidelines incorporate sequential non-invasive tests where you start with, say, a biomarker like FIB4 and you chase it with FibroScan. And maybe that's why it's a poster and not an oral, but I don't know. I don't want to throw water on your abstract or on the authors that created it, but I just find that maybe a limitation of the study.
Oh, absolutely agree. There isn't any definition in the study as to how many of those patients were biopsied. It just gives one of those three as the reason for defining cirrhosis. So it would be, now having personal insight and having seen that study start, a lot of those patients came in for biopsy is my understanding, but I couldn't tell you exactly how many went further for that. But they were, and I suppose what they're trying to do is a real-world model of what might happen. So even by definitions by that, and I suppose you could argue that FibroScan should pick up a higher percentage of cirrhosis potentially than 3%, given that probably a 12.1 cutoff will mean that maybe only 1 in 10 actually has cirrhosis. The other 9 won't at that length, at that lower cutoff. Higher cutoff, probably a lot more. But I think what it went on to show was the best way of defining and working out the cost effectivity, all of the measures, whether they use BIMAS, so BMI and AST and FibroScan, but all of the measurements were cost effective. And I think that for me is the outcome, is that the way that we look at being able to subpopulate a diabetes population, there's an argument that we shouldn't do it because of the cost. Actually, all of these sort of stratifications proved highly cost effective with FibroScan and BIMAS as the two combined together that they worked out for their study did. It's been 4 years, I suppose, or 3 years, and a pandemic in the way. So it's nice to see some data coming out for it. And this population is paired in another poster looking at gut permeability, which is an interesting one as well. So they've used the same population for a couple of things from what I can tell. It was just nice to see it come out after all of these years, and duly noted in the context that I can't tell you from the data that's given in the abstract how many patients were biopsied, suppose if any, on that one.
My take on this is, and Stephen comes from the drug development aspect, of course, and how should these patients be enrolled in trial, how severely are they, how advanced are they? I think what the abstract will tell us in a diabetes population, how it's more like a prevalence. How often can we look at a KPA above 12.1? And the answer is 3%. Now we'll see data emerging what that means. What does that mean for a patient if his KPA is about 12.1? It doesn't mean he's cirrhotic necessarily, but we'll learn about the outcome. What does that mean 5 years down the road? Are they getting more problems? Is this the highest risk category we have to focus on in clinical care, the diabetologist's care, or something like this? I agree with Stephen's comment that there's positive predictive value, and we've discussed this a lot. I wouldn't call it cirrhosis, but it informs us on the size of the problem, I guess, in the diabetes population, on how often we're going to see 12 KPA and above. I guess that's my take on that data set.
Absolutely. And thinking back to what Roger was saying, there's a little bit of a theme through what I can see with the posters and the presentations. It's about real world data, and it's about how do these scars conform with each other's, because one of the other ones I've looked at is the shear wave elastography, transient elastography, enhanced liver fibrosis used in assessment of NAFLD in the real world practices. How well do they do? And I think it's Elena Ionosi is presenting this one, and that was basically aiming to the risk stratification of patients using the non-invasive tests can be challenging, which is what we know. And how was that going to be looked at throughout those populations? So they did a comparison in a type 2 diabetic population with hyperlipidemia using FIB4 score of more than 1.45 they chose. So they then went to hepatology for elastography by FibroScan, shear wave by Acuson, and what they found was they looked at a big population. They looked at 13,953 and got it down to just over 4,000, met the criteria for a second screening round with a FIB4 of over the 1.46. So what they ultimately concluded was that high-risk NASH populations can be identified applying the simple algorithms and using economic health records as a point of source, so that we don't have to just bring patients in or look at their bloods by looking at their electronic records, which is where they got started off with their population, that we can use the shear waves, the transient elastographies, the FIB4s, and they work relatively well in a real-world practice. Again, it's about how do we put this out and implement it, and do they correlate with each other well enough to be used? So again, a study that looks to use those non-invasive rather than a biopsy-proven population.
This is slightly tangential. Steve and I had a conversation maybe 4 or 6 weeks ago, not on this podcast, about the level of drug discovery being presented at this meeting being relatively low to what people had become accustomed to in recent years. One of the reasons for that, I think, being in the aftermath of Intercept and the pandemic, all the drug trials slowed down, right? And in the aftermath of the pandemic, certain other kinds of research weren't easy to do immediately either. So it's not surprising that you'd see a larger number of these kinds of population and retrospective analyses, because those were the data streams that weren't going to slow down in the pandemic. Now, I'm kind of making this up as I go along, so you guys could tell me I've got it wrong. But it seems to me that that's one of the effects of the last couple of years in terms of how research has gotten done.
No, I think it makes sense.
For sure, clinical trials slowed down. I mean, we probably are seeing an impact of that at this year's meeting. And I suspect any situation where patients had to come to clinic, sign consent, and have a procedure done, the more invasive the procedure, the fewer of them that were done. Just look at liver biopsy. I mean, you had endoscopy suites shut down, IR suites shut down, and that was probably the largest percentage of things that were shut down. Next would be MRIs. And then next would be things you could do as point of care, like come to the clinic, get a FibroScan, get blood drawn. If the patient was willing to get in the car and there was a nurse or a sub-investigator or a phlebotomist that was willing to come to work, you could put those two together probably more quickly than you could. Is there a scanner that's open? Is there a rad tech willing to do the scan and the patient's willing to drive and sit in the waiting room? Versus an interventional radiologist that's doing an invasive procedure, where I can tell you in many parts of the United States, all that shut down for many, many months on end. I mean, it's not surprising that drug development reporting would be down. And then what can we report? We can report and continue to enroll trials where, there was less invasive things being done and less time in the doctor's office, and patients could get in and out relatively quickly. So it's still good data.
Yeah, on the other hand, Stephen, I'm really excited to see some of the clinical trial data going to be presented. We're not allowed to discuss them today because they're embargoed. And needless to say, I think you're going to be presenting resmetirom data, but also a dual agonist, I believe, a GLP-1, a GIP-1. Very exciting because there's a lot of stuff coming there. And then there's a late breaker in a cirrhotic population, even a study that I was involved in, and is going to be presented by Rohit Lumba. I think we do have the clinical trial aspect. It's not as rich as it used to be, but there is a number of concepts that are being brought forward, and they're all embargoed at this time.
Yeah, and I think it'll reemerge over time, Jörn. This is a lag effect of the pandemic, really. You couldn't get people to do things for a while and slowed stuff up. If you were collecting large cohort population data, particularly if you're collecting it before 2020, then in fact you shouldn't have been affected. So the paper I'm going to talk about, which is OS44, I believe it presents on Friday morning, titles Non-Alcoholic Fatty Liver Disease Patients Have Worse Health-Related Quality of Life Compared to the General Population. And here's the kicker: irrespective of their fibrosis stage. Results from a prospective multi-center UK study. The lead author, please forgive me if I pronounce her name too badly, is Margarita Papatheodoridi, but she works in Manolis Tsakakis' I'm screwing up names all over the place, please forgive, lab. So basically, what they looked at were, they took 561 patients with NAFLD from different secondary care centers between 2016 and 2019. And patients completed 2 different quality of life questionnaires, the EQ5D5L, which I'm not that familiar with, and the chronic liver disease questionnaire, which I know a little bit better. And they ran these against demographics, clinical information, liver stiffness by transient elastography, and or biopsy results, same kind of thing you're talking about. They don't talk about which. And they say history of cirrhosis, but it's not clear in this abstract, at least, how they're defining a history of cirrhosis. With that said, they compared population to a out alcohol misuse that completed the 5EQ, 5D, 5L as a comparator. And then in the NAFLD patients, they also did some propensity score matching according to age, sex, and body mass. What they found, not surprisingly, was that the quality of life scores were lower. The EQ5D, 5L index was lower in 514 NAFLD patients compared to the matched controls, and significant in a subgroup of NAFLD patients without advanced fibrosis compared to the general population. So one of the things we've been talking about is how the effect of steatosis versus fibrosis and how bad does the liver have to be for the quality of life score to be affected, and this says not all that much. Their definition of advanced fibrosis is less than F3 and a VCTE liver stiffness of less than 8 kPa, so fairly low. And basically, those patients without NASH do worse than the overall population, okay? They go on to say that patients with cirrhosis score lower than the NAFLD patients we just described. However, among the NASH patients, once you get to NASH, there is no difference whether you have advanced fibrosis or not on any of these measures. They talk about the index being negatively associated with type 2 diabetes, depression, osteoarthritis, not surprisingly, in the whole patient populations without cirrhosis. I think the punchline, when you get to it, is first of all that NAFLD in and of itself is a predictor of lower quality of life. And the cirrhosis then is a predictor beyond that. But NASH might not be. So one of the things that Jörn has been talking about a significant amount recently, and others before that, Manal being one of those who comes to mind, is the importance of looking at quality of life. And they were talking last week in Global Liver Day about the reason the slogan is Stop NASH Now is because if we can simply stop progression, that would help the quality of people's lives. This, I think, says yes and no, right? It says that once you get to NAFLD, you are already going to have an impact on quality of life, which means we can be measuring against that in trials and other settings, and that'll be true for everybody, worse when patients get to cirrhosis. Again, I don't know how they define history of cirrhosis. I don't know how many patients got biopsied as compared to simply had a VCTE, but those would be what the results suggest.
I think that's an important study, Roger. A couple of things that come to mind is they're using two tools. So they have a liver-specific tool, which the CLDQ, as you said, and that's capable to pick up this tension of the liver capsule and some of that right upper quadrant pain, the tiredness the liver patient has. And it has a generic tool for which you can actually compare to the general population. There's no CLDQ for the general population because they're not liver safe. So the EQ5D you can compare to the general population, and then they fare worse. My take home is that a lot of that comes from diabetes in this context, and I think you have to look in where these patients were recruited. Now, it's secondary care and it's a general population, so the prevalence of really advanced fibrosis isn't going to be too high. I don't think they say it in the abstract. We'll have to see how it is on the poster. But I think one reason why it's not showing up too strongly here with advanced fibrosis signal is that it's probably the prevalence is not very high in the cohort. There's actually been some good studies in the literature, also from consecutive studies showing improvement of fibrosis being correlated with quality of life, liver-specific quality of life, that is. And as such, I am, from what we are seeing, actually, if you get a strong enough signal in the advanced cirrhosis group or advanced fibrosis group, you should be able to detect it. Having said that, I think this is a very important study because it highlights this frequently neglected aspect of how a patient feels and functions, and as a physician, that couldn't be more important. And for the patient, I think it is in any case.
Where I think this is most widely applicable is in really helping to build the premise that we need to be screening for these patients. Because it's not just about increasing rates of mortality, but morbidity. And morbidity often is how a patient feels is often overlooked relative to progression to end organ damage, not linked to liver death or liver decompensation or cardiovascular disease. This has been borne out over and over again. Somehow, people manufacturing drugs or studying drugs for fatty liver need to build this into the studies. And then not only that, they need to take this data and build marketing outreach campaigns to providers to say, these patients are impacted, their quality of life is impacted. And somehow, we see this presented at meetings, we see it published in the literature, but very little happens with it after that. It just kind of gets pushed to the side aside and we have discussions more around something that's granular and palpable, something that we can touch and say this is impacting a concrete endpoint. And I think too often what we fail to realize is that fatty liver is a disease continuum. Fatty liver is a problem that patients live with for decades generally, and they can begin to feel less well in some regard long before they develop liver cancer, kidney disease, diabetes, complications of diabetes, liver-related decompensating events, liver-related need for transplantation, or cardiovascular disease or death. So I like it. I think we need to use this and leverage what it's telling us.
So, Stephen, I think those points are excellent, and I've got two thoughts. First of all, the individuals who probably can have the greatest impact on getting this stuff into trials are I'm not putting a bullseye on you, are the people who are both clinicians and help folks design trials. Because if you're not a clinician and you aren't focused on seeing patients in the reality of practice, you're going to miss this stuff. And because of the relationship between how trials get done and when marketing research gets done, it's not likely to get picked up in a lot of other places. But clinicians who are involved in trial design are the ones that say, hey, listen, this matters more than you know, number one. Number two, from a marketing perspective, I thought this study was incredibly powerful because right now we've got doctors all over the world saying to patients, you've got fatty liver, but don't worry about it. And you got this study saying that if you've got steatosis all the way up to cirrhosis, certainly up to NASH, up to fibrosis of F3, you're going to have a negative impact on quality of life. And whether you catch it simple steatosis or at F1 or F2, same deal. So to all these people who are saying it doesn't matter, we should be taking quality of life and depression screens on these folks and seeing if in fact it does matter, right? Because if it's affecting your quality of life in any way and we can treat it, we should be treating it. And we don't even think about that right now. So I think those are two separate issues, but the marketing side might be one of the motivators that the folks who are helping the clinicians design trials use to understand that as you talk about quality of life, you're actually expanding the target population immensely.
Yes, but if you take it one step further, 1 in 4 of the global population have fatty liver. Most of them don't have NASH. Those are people who work for a living. And if we're saying that the quality of life is poorer in those patients, not only does it affect the NASH studies, it affects the working population. We've already seen the EASL Lancet report in December say that liver disease and poor liver health basically was the second leading cause of working lives lost. But we've got presenteeism, we've got poor concentration, we've got all of the common things that happen with fat in the liver. So it is a massive problem. It's not just for the clinical trials. And if you've got liver fat in a fatty liver population, you also have liver fat in most of the other clinical trials for any other disease, particularly cardiovascular. We're just not measuring them. We're just not doing anything other than a blood test to rule out liver damage. So if you extrapolate it even further, the quality of life studies in most of the other studies for diabetes and cardiovascular are adversely affected by the liver fat in that population.
That all makes sense to me. My comment was from the perspective of what could I prove as a marketer or as a marketing researcher or as a forecaster. And these are things I can prove. Significant portion of the population, quarter, 3/8, big numbers, have fatty liver disease, that 80% of those will never progress to fibrosis, right? So why would we worry about treating those folks at all? The answer is because their quality of life gets dinged in a major way, particularly, as Jörn points out, if they have diabetes or concomitant conditions. The three they listed were diabetes, osteoporosis, depression. I think depression is an aftermath. You are depressed because of all this, or you're more likely to be depressed because of all this other stuff. But you can see where osteoporosis and diabetes would be at the front end, depression would be at the back end. But we're not even thinking about that. So if a patient comes in and they're depressed and you don't have markers for, check their liver. And if you find it in their liver, treat their liver. And that will expand the treatable population for the disease in a way that is completely ethical, but we would not have been thinking about if we weren't thinking about the feel measure of, feel fit, survive, which is why I think this matters so much commercially.
Roger, if I may follow up here, I'm just going to come in sliding here for a second and say that we have a similar abstract submitted in a population that's diagnosed, been living with HIV. It fits in nicely, so I'm just going to quickly wind this up here before I'll hand over to Stephen. Because this is an abstract, we're going to be presenting it on Thursday. It's abstract number 051, and first presenter is going to be Maurice Michel, a fellow of mine. And we have a fairly big patient group diagnosed with HIV HIV, we used CAP and VCTE to define hepatic steatosis in that group, and we used the cutoff of 275 decibel per meter. The prevalence of hepatic steatosis was actually 25% in that group, and we used the same tools as in the abstract previously here, the EQ5D5L, and actually it comes out similarly. It's not depending on the advanced fibrosis, or at least we didn't look at it from that way here. It's the presence of hepatic steatosis that impairs the quality of life, and importantly the dimensions, mobility and pain and discomfort were significantly lower in the population of patients living with HIV and exhibiting hepatic steatosis compared to those patients living with HIV and not being positive for hepatic steatosis. But, this is a population we're normally looking at. They have a lot of problems, social, educational, financial, and even in that population, if you're exhibiting hepatic steatosis, mobility and pain and discomfort are significantly worse compared to a non-hepatic steatosis person living with HIV.
Yeah, just to compliment Jörn on the work that he's done. I mean, I think there can't be enough of this. We need more of this data just to augment the data that Louise mentioned as well. Circling back to the point you made, Roger, we have to do a better job of getting this recognized in the literature and then translating that into some tangible communication to primary care providers that we need to do more than just say you've got fat in your liver, lose weight, you're good. But let's spend a bit of time diving into how that patient is really doing relative to the fatty liver. And look, I get it. There's not enough time to do everything. But at some point, at some visit, there should be a discussion about quality of life. I'll be the first to admit I don't do it in my clinic. I don't have enough time to do it, but the more and more I hear about this, the more I read about it, I'm convicted we need to spend a little bit of time on this. And where work like Jörn, your fellow, where they can guide us is tell us what the most important things are that we need to be asking relative to quality of life.
Stephen, I think that's a great point, and it raises two thoughts in my mind. One, this seems tailor-made for digital therapeutics, right? This is the kind of thing, it's easy to scale and get people to answer. You can turn it into, you can use gaming and projectives and all kinds of techniques that work out well in digital therapeutics and nudges as a way to get accurate answers from people. And because it isn't, Stephen, it isn't just tell us about the questions we should be asking. It's you have the sensitivity to ask those questions in a way that your patient knows you mean it, and the answer they give you is reflective of a deeper truth. But most of the doctors I see, if they ask the question, it's because they know they're supposed to ask the question, and it feels like pretty pro forma. Lay doctors, not the academics, number one. Second thing is this. I don't remember if we were talking about this last week or 2 weeks ago, but one of the things you were going to talk about, I think today, was maybe liver volume. And liver volume feels to me like one of those subjects, right? Liver volume leads to an increase in pain. Increase in pain relates to quality of life. So liver volume might have an import that goes beyond the effect it has on fibrosis per se. And if we turn more to think about the quality of patients' life, that might be one of the things we pay more attention to. Just a thought. I think with that, Stephen, you're up.
Okay. I know we're running out of time here, so let me just try to just briefly go through one that I found quite interesting. This is one by Quentin Anstey's the first author. It's entitled Non-Invasive Fibrosis Scores as Prognostic Biomarkers of Liver Events. Okay, that's not real exciting, right? Because we hear that all the time. But also cardiovascular events and all-cause mortality in a patient population of obesity and type 2 diabetes in the UK. This is a longitudinal cohort study, so it's a large study. Patients over 18 with obesity and or type 2 diabetes with a fibrosis score of greater than 1 were included, and a total of almost 45,000 eligible patients had measures available for non-invasive testing. The non-invasive test of record that was utilized in this particular abstract was FIB4. So of these 45,000 eligible patients, there were almost 1,000 liver events, of which ascites was the most common, cirrhosis next most common, varices the third most common. If you break the FIB4 score into its three different categories, less than 1.3, indeterminate, which is 1.3 to 2.67, and then greater than 2.67, you can begin to look at the these events. And the really nice thing about this abstract is there are 3 different graphs, 3 different figures. One looks at liver-related events, one cardiovascular events, and one all-cause death. And so using those 3 cutoffs for FIB4, if we look at liver events first, and the FIB4 is less than 1.3, only 1% of people had a liver-related event. And this is with 10 years of follow-up. And if it's indeterminate, it's 3%. But if it's high, greater than 2.67, 15% of people over this time period had a liver-related event. That's the cumulative incidence. If you look at cardiovascular disease, the low is 11%, indeterminate 27%, high risk 33%. So again, showing that FIB4 can really begin to predict not only liver-related events, but cardiovascular events. And then all-cause death even gets wider. So it's 13% for low FIB4, 37% for indeterminate, and 61% for high risk. The conclusion here was that in a real-world population of patients with obesity and or type 2 diabetes and no other clinically recognized liver disease, the risk of a clinical event was significantly higher in patients with high versus low FIB4, highlighting the prognostic potential of FIB4 in this population. I think this is incredibly important because we are in the middle of a renaissance. And this renaissance is we want to move away from liver biopsy. We want to begin to find simple, non-invasive strategies to risk stratify our patients, to prognosticate our patients. And we have begun to do that, but for a long time, we have compared these non-invasive tests to liver biopsy, which we know is an imperfect gold standard. I mean, people have used the term bronze standard. It's not very consistent, lots of variability. So here we have a situation where we have thousands and thousands of patients followed for a decent period of time, and we're able to say that the simple non-invasive blood-based biomarker can predict outcomes. So why can't we take that data, put it into the blender, and use that to help us in drug development, working with regulators to get beyond the biopsy and begin to use this to quantify risk and use it to determine whether a drug is potentially helpful or not. So there's a lot of applications, I think, that will be helpful and useful from data such as this. But I found this abstract to be, in my book, one of the highlights of the liver meeting at EASL this year.
This was my second favorite abstract, and for reasons you articulated, but also for one more. If you take a look at those 3 graphs again, right? If you visualize it in the liver outcome, indeterminate is very, very close to low. In the cardiovascular, it's very, very close to high. And in the all-cause, it's somewhere in the middle. I don't know exactly what to make of this, Stephen, but it struck me from looking at this that FIB4 had some impact specifically in understanding which people with fatty liver had relatively high cardiovascular risk. I mean, those lines are really close. It led me to believe that the word indeterminate is getting a bad rap here, frankly.
What this shows is, and this is with a single blood-based non-invasive test. Imagine if you put that with an imaging study, potentially what that could tell us. There's even more refinement that can be had. But this as a first shot over the bow, I think is incredibly eye-opening and insightful.
I think the thing that frightens me slightly when I look at this in implication is when we look at our children and the amount of obesity in children. This is only a 10-year paradigm, and yet we now have 8% of all children at 5 in Europe living with being overweight or obesity. This does not bode well for our figures and early mortality in years to come unless we really, really do start to change some of what we're doing now and the way we're managing. And going back to the previous one on quality of life, getting to the nitty-gritty to primary care, that actually it really, really does matter that we concentrate on what we've got now, which is lifestyle management and better information to get out, because I just fear the quality of data that's coming out in this one and this prediction that our young generation are not going to survive very long at this rate.
Here really the power of big numbers comes in, and the authors and Quentin in the lead should be congratulated for pulling that data together, because it gives us the number of events we're not seeing in these smaller single cohort studies, and also the follow-up is long enough to actually pick something up. And we have not seen a lot of those data sets. There's a lot of them from the Swedish registries that have linked electronic healthcare records and death certificates, and it's good to see something here on this being replicated in the UK, and it informs us on the size of the problem in Europe.
I agree. So one last point about why I was heartened by this particular abstract. As we start to look at all the clinical care pathway recommendations and guidelines that are coming down the pike, most of them are starting with FIB4, right? Grounds being it's inexpensive, it's easy to get your hands on, and it's got it's got really good negative predictive value. But this says maybe it's even a little bit better than that, right? Liver, in fact, might be the place where, on high, liver is very good. But if you use indeterminate also, that becomes pretty good on understanding cardiovascular. And if you go back to Jörn's comment on the previous paper, which is that a lot of this has to do with the intersection of diabetes and fatty liver, we know already that fatty liver disease predisposes a worse outcome to diabetic patients. And this says you can actually start to pick that off with the FIB4 indeterminate score. Maybe it means their liver isn't clearly in jeopardy, but it means that by not treating their liver, you're putting their cardiovascular system at greater risk. So it's a really interesting way to look at that population to me. And I think a lot of momentum we can take from it. And we are now at the bottom of our hour. So if anybody has any comments about other papers you wanted to mention briefly, for whatever reason, take a moment and do that now.
Well, I would just say there's quite a bit of data coming out relative to non-invasive tests that we didn't get a chance to mention today. Despite what we said at the beginning, there are some good clinical trial data coming out, many of which is embargoed and we couldn't speak about. So we do feel like this is going to be an incredibly informative meeting. I can't wait to get there, and not only to see Louise for the first time, but in person, but also to catch up with old friends and colleagues and see what the latest and greatest is that's coming out in liver disease, despite the pandemic and everything else.
Couldn't agree more. I'm really excited about this meeting. And yes, I totally agree. The drug development papers we can't talk about that have been embargoed, the three that you mentioned, I think they're all very important and really exciting, or that Jörn mentioned or whoever mentioned. But yeah, this meeting has a ton in it, and I will be excited to get there. Closing comments. Pick one thing we did not talk about today that's going to be in this meeting that you think is particularly intriguing. Just take a minute, make it brief, but just one point. Brave one, go first.
I'll go first. The first day, and maybe Jörn is, you're tied in more to the European meeting than I am, but it's one of these think tanks, and I haven't ever thought about the think tank idea before, but there is one on fatty liver disease. I think it's the first day, like the 22nd. I'm excited. When I looked at the schedule there, I'm giving a talk there on mitigating screen fails in clinical trials, and that's just probably the least interesting of all of them. There are many fantastic lectures in that session, and then a great roundtable. So it's not presenting novel new data in a sense that it's not a clinical trial, but it's how do we do what we do better? How do we do these clinical trials better? How do we, get more of the people that are interested in trials into the trials and across the finish line? So I'll just throw a plug for that.
Well, yeah, that session has a remarkable cast of characters. You, Quentin, Vlad, Luca Valenti. I don't remember who else, but there are one or two others. I want to thank you for making me get up at 8:30 in the morning the day after I land while I'm brutally jet lagged to go to that event, but I will be there.
Let me highlight a session we're giving on, I believe it's Friday morning. It's kind of the follow-up of the early morning breakfasts that they used to have. It's on Friday morning, so it's another 8 o'clock, and it's called One or Many Fatty Liver Diseases, a clinical impact on disease heterogeneity. And there's a fellow that's going to be presenting a case, and then Hannes Hagström, Luca Pei from France, and Dina Tiniakos are going to be discussing the different aspects of that case, making it very practical and hands-on, because there's so many aspects in fatty liver disease that might make the presentation in clinic a little different. What's the amount of alcohol? What's the genetic background? Does the histology tell me what this patient will experience? Maybe it has a heterozygous change of HFE gene polymorphism or alpha-1 antitrypsin. And as such, we're hoping to highlight some of that heterogeneity that exists in clinical trial, or not in clinical trials, but in clinical practice. And I think it's a great session where we're aiming to resolve some of those controversies.
I think I'll jump in next. And I suppose for me, as I'm covering a fair amount on the Saturday, it's the public health session chaired by Nick Sharon in the morning and Helena Corres Pinto. So they're looking at various things from abdominal obesity and alcohol and obesity, liver disease, public health reduces burden of mortality in alcohol, smoking and alcohol consumption. So they're looking at a fair range of different sort of social aspects, which will be an interesting set of sessions because I think public health, we all don't lead a perfect life and not one disease is not affected by other people's lifestyle components. So that will bring an interesting context to some of it for me.
I agree. And as I mentioned, I have to fly home on Saturday for memorial service on Sunday, but there's a session at 8 o'clock on Saturday morning as well that you have a paper in, and also the Jenny Lee paper that you mentioned is there. Amazing. Those two papers, Rohit has a head-to-head comparison of MeFit, MAST, and FAST for detecting candidates with stage 2 fibrosis. All 5 of the papers in this session really look fascinating to me, and the idea that they've got Jörn hitting cleanup feels completely appropriate in a session of power papers. I think that's about the way it should be, Jörn. So with that, we will be talking with you folks next week from London, and we'll be doing something on Monday, but I'm not sure. Monday may just be interviews, so we'll see. And then we'll have sessions, as I say, on Friday and on Saturday. I'll be back in a couple of minutes with the business report. Everybody say goodbye.
Bye, guys. Thank you.
Goodbye.
Goodbye.
Okay, thanks, everybody. And I'll be back in a bit. Bye-bye.
And now for the Season 3, Episode 30 Business Report.
Slava Ukraini, Heroyam Slava. This war keeps going on. Let's just hope that things stay good for the Ukrainians and that we're moving towards an outcome that will make us all happy. I want to start today by thanking those of you who joined us during our wrap-up panel at International NASH Day last week. Over the course of the day, I learned a lot from the GLI sessions, and during our panel, I made a few new friends and contacts. And with that, let's look ahead.
It's official, our special targeted podcast, The NASH Tsunami in Diabetes, Getting Ahead of the Rising Tide, released last week.
Our first episode of the Diabetes series is officially launched and beginning to build an audience. Also, work has begun on the second episode, which will go out early in July. Remember what I said last week. You will notice one difference with this special Diabetes series. We need you to enter through a very short questionnaire we've created. This is for the sponsors and potential sponsors who want to understand a little more about our audience. But what it means is you cannot enter through your normal podcast or Apple, for example, or Spotify or Google. And it also means that we cannot send reminders or promotional messages through your podcaster. If you want to hear the podcast, you can find a link to the entry gate on the surfingnash.com homepage. And if you have any problems entering that way, please send the questions at surfingnash.com so we can fix it promptly.
Did you like the videos we posted?
Last week, we did something we'd never done before. We posted videos of our regular episode and linked to GLI's Thursday night wrap-up episode video. We're looking for feedback from you on how you felt about Surfing NASH on video and whether we should be incorporating more video output into our weekly releases. Again, all feedback welcome. Questions at surfingnash.com.
ILC 2022 is next week.
At EASL, we will have same-day coverage next Friday, June 24th and Saturday, June 25th. I will be flying home Saturday for a personal event on Sunday, so Louise will be hosting that episode. We will have something appropriate pre-EASL on Monday, and we'll have special guests with us throughout the week. Keep an eye on LinkedIn, Twitter, and our news source, Instagram, for information on what we're doing.
Download totals keep rolling along.
Okay, it's only Monday afternoon as I record this, but this week's downloads look likely to surpass 1,200 again, and the week already has well over 5,000 as a 28-day total. Our Google page views are rising as well, and our LinkedIn impressions stay over 1,000 a week. The vault numbers this past week have been interesting. There's been virtually no uptake more than 3 months old, but episode 17, Scott Friedman and Neil Henderson discussing the mRNA CAR-T paper and more on omics, was our second biggest upload from past a week ago. Episodes 25 through 27, the Drug Development Crystal Ball, Quite Nancy's episode on NITs, and the Global NASH Review continue to grow well. And with that, I'm off before my voice, which is getting better, completely disappears again. I want to thank our team, Magic Mike, Eric, Steve, Murph, Magnificent, for a great week. I want to thank you, our listeners, who keep downloading and signing onto our various source pages, some of whom we got to meet online for the first time last week. So with that, I'm done. Stay safe, surf on, get ready for EASL. It's going to be really exciting. As you can hear from today's episode, some fantastic papers coming, and you'll be hearing a lot from us next week. Bye-bye now.
Today's episode of Surfing the NASH Tsunami has been sponsored by Madrigal Pharmaceuticals, a clinical-stage biopharmaceutical company pursuing novel therapeutics for NASH. Madrigal's lead candidate, resmetirom, is a once-daily, oral, thyroid hormone receptor beta-selective agonist that is designed to target key underlying causes of NASH in the liver. Resmetirom is currently being evaluated in 2 phase 3 clinical studies, Maestro-NASH and Maestro-NAFLD-1, designed to demonstrate multiple benefits in patients with NASH. For more information, visit www.madrigalpharma.com.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.